So thank you for joining our weekly Center for Healthcare Policy and Research seminar series. Some of you have come for a lot of weeks and some of you might be new. We have a lot of really great applied research topics, and we rotate around topics from policy to clinical integration, community engagement, and the like. So this week we're super fortunate to have Dr. David Liss from Northwestern come and speak to us about his health services research portfolio with a specific emphasis on receipt of care for marginalized communities and some of his partnerships, I believe, with some safety net healthcare centers that he'll speak to us about. Um, Dave is a colleague of mine and also received his PhD in health services research from the University of Washington, but he's been in Northwestern, I think, over 10 years now, something like that. And so a true expert in health services research, applied methods, quality measurement, a whole bunch of different topics. So we're really lucky to have you with us today, Dave. Take it away.
Okay, well, thank you, Courtney, and thanks everyone else for joining. Give me a moment while I share my screen here. Okay, people see that?
Looks great.
Good, okay. All right, so again, thanks for having me today. I am here to tell you a little bit about sort of two topics that I've been working on and thinking about the last couple of years in hopes of stimulating some discussion. It's not a journal club session that I've prepared, but what I'm hoping to do is sort of plant the seeds, tell you a little bit about some of these sort of sandboxes I've been playing in that hopefully are of interest to you and maybe something that some of you actually all work on yourselves, and just stimulate some discussion about these areas that are some kind of bread and butter or newly bread and butter topics in primary care, and hear what people sort of think and have to say about given what we know and what we don't know and what we're learning, what are some ways we can be doing things in efficient, effective, high value ways in healthcare. So again, I'll talk for a little while, but I got sort of two topics and we'll go through them one by one. I'll talk a little bit about each topic and then I'll open it up for discussion and feedback for the group there. Just for some formalities, I have no disclosures. As Courtney mentioned, I'm a health services researcher. I very broadly describe my work as health services research to improve the quality and value of primary care delivery. I overlapped with Courtney at UW back several years ago now. Not only were we in the same PhD program, but we overlapped in some of the sort of work we did. Specifically for my dissertation, I was at an organization that was called Group Health Research Institute, which was the research arm of what was Group Health Cooperative, which is now part of Kaiser, which I assume you all sort of know well. These days, I continue to be faculty at Northwestern, as I've been for like a dozen years now. I also have an appointment. I spend a little bit of time at an organization called Alliance Chicago, which, amongst other things, it provides sort of health IT hosting and services and also quality support for fairly qualified health centers, many of which are in the Chicago area, but they have clients and partners sort of nationwide. So that's some of the more sort of some of the ways I work in sort of safety net and FQHCs. So today I've got two topics to talk about. One is checkup visits in primary care, and specifically which group or groups sort of can be or should be targeted or prioritized in sort of high value to maximize the value of these visits. And then the second topic is screening for health-related social needs, sometimes called social determinants of health or social drivers of health screening. I call it health-related social needs in terms of more like screening patients for immediate needs that they may be having at the time of screening, whether that's over the phone or in clinic or some other way, in some other spot. And again, thinking about sort of potentially feasible and sustainable models for screening programs, given what we know and the many sort of unanswered questions that we have. So, on that note, let's get started with sort of our first topic here. So, checkup visits and maximizing the value of checkup visits. So, when I talk about checkup visits, what am I talking about? Well, I got this, we got a technical definition here that I created with some colleagues in a publication we had. Talk about it being a healthcare encounter. It includes multiple screenings, as well as identifying risk factors with a goal of initiating early interventions and preventing future illness. Beyond that very sort of technical, jargony definition, um, I've often heard these visits described as um, general health checks or preventive visits. I like checkups. I think it's a little simpler, a little more sort of easy for patients to understand. But there's certainly variation in the terminology. Generally, since around 2010, and when the Affordable Care Act was signed, these visits have typically been covered by insurers, both private and Medicare, as well as often Medicaid, typically covered by insurers at zero copay. What I don't like to call these visits are annual physicals. This is a term that we hear a lot. In some ways, it applies maybe to well child visits for pediatrics for kids. But when we talk about adults, which is what I'm talking, which is the field I'm most interested in, these visits, these checkups, they're not always necessary to happen every year. So that word annual isn't always appropriate. And there's no convincing evidence to show that a physical exam is actually beneficial. Patients may want it, patients may expect it, but there's no known benefits beyond things like checking patients' blood pressure as well as their body mass index. So I steer away from annual physicals, but again, that is a term that's also used somewhat as of a misnomer to describe these visits. So what's good about these visits? What do we care about them? Well, I know they're so common, but let's be very clear or as clear as possible in terms of what kind of benefits do these visits actually offer. There was a review I published with some colleagues here. I got the title listed there. So we looked back somewhat comprehensively through the literature for decades. There is both randomized trial as well as observational evidence that these checkups are associated with, and in many RCTs have been shown to increase preventive services, recommended preventive services, certainly not shocking for these types of visits, as well as to increase diagnosis and treatment of previously unknown chronic illness. So it could be, screening for diabetes, certainly screening for things like hypertension, things like that. Certainly, I think easy to sort of comprehend that. Another area where there's really clear randomized trial evidence that I think is maybe not as well known is that these visits improve patient-reported outcomes. Not only is that things that can be desirable overall, but when we talk about things like self-rated health, that's a metric that's associated with mortality pretty strongly. So these are some pretty important things. And also in some of the RCTs, so there have been what we identified 4 randomized trials in older adults. The most recent ones in the US were like 30 years ago, one of which was actually at Group Health, Courtney. It was Donald Patrick was the lead author of that study, just as an aside there. Um, but in older adults, there have been 2 randomized trials that were in our review, and there was reduced mortality in 2 out of 4 of these randomized trials for adults age 65 and up. So certainly not ubiquitous reductions in mortality, but certainly nothing to we don't want to ignore that. So we're talking about very clear increases in preventive care uptake, improvements in patient-reported outcomes, and potentially reductions in mortality for older adults. Like many things in healthcare and health services, there are disparities in uptake of and completion of this evidence-based intervention. Checkups in general have been found to be more common in relatively advantaged patients. So it could be patients with higher education or income, people who are more recently attending primary care visits, more motivated to be sort of actively participating in their health and their health care. There's something called the Medicare annual wellness visit, which some of you may have heard of. It's Medicare's version of the checkup, again, covered with zero copay for Medicare enrollees. Specific research on that has found low Medicare annual wellness visit or AWV completion in minority patients, particularly patients of Black race, as well as patients with low education or income. Probably not a shock to those of you here, but has been found in the literature. It's also backed up by work that we've done in our health system. So here's some results that'll hopefully be in a peer-reviewed publication very soon. We're doing a study of these Medicare annual wellness visits at Northwestern Medicine, the health system that's affiliated with Northwestern University. And they had a 2-year intervention to boost Medicare annual wellness visits across the health system. What we see here is AWV completion broken down by race ethnicity across a 3-year period. So the year zero, there are those bars on the left. Pardon the fact that they're all purple, but there are those shorter bars all on the left there. And what we see is that this sort of uniform increases across race ethnicity. In total, in this population that was majority white, AWV completion was in that year zero, the pre-intervention year, was about 47 or 48% overall in that year zero, and then got all the way up to 69% in year two. So we see big increases across the board, but looking between these racial and ethnic groups, we see these disparities that are virtually unchanged across the 2-year intervention. So while we do see this sort of rising tide of sort of all boats being lifted within the intervention, if you look at these first sort of cluster of bars, which is the white patients, versus the second cluster of bars, the Black patients. So in year zero, 48.8 versus 38.4, we see a 10.4% white-Black disparity in year zero. 2 years later, it's a 10.3, virtually identical disparity 2 years later. Similarly, for white and Latino white versus the Latino Hispanic group, it's 11.9% disparity in year zero and 10.9% disparity in year two. So we see these not only in the broader evidence base, but in our health system. We see in this type of intervention, which was not explicitly designed to reduce disparities, something we're working on going forward here. We see these persistent disparities, again, nationally as well as in our system, which is in and around Chicago and Illinois as well. All right, I'll try not to bore you too much. I don't want to have too much of a laundry list of the evidence, pardon me. But so just a note about who's providing these tour checkup visits. I think, sort of typically or the prototypically, people would assume that they're being delivered by a patient's primary care provider. Could be a physician, could be a nurse practitioner. However, there's a good literature showing that it's at least feasible for non-physicians to deliver these checkups. There's a couple studies I cite here. One looked at nurse-led checkups that were led to increased preventive service completion, and the author said it allowed physicians more time to focus on chronic and acute needs of patients, i.e., physicians didn't need to take the time to do these preventive visits. This other study by Galvin and colleagues, they actually stratified, I think there was physician sort of supervision of these providers, but they had pharmacists for some of the higher need patients and LPNs for some of the lower need patients providing these checkups, again, associated with increased preventive service completion. As far as I know, they didn't look at things like mortality or patient-reported outcomes, but certainly for the preventive service completion, not surprising, we see this consistent sort of results. I will say on this issue, I think as probably some of you know, this issue of doctors or primary care provider for someone who is a nurse practitioner as their primary care clinician or primary care provider. We've seen in our own focus groups, we've seen varying perceptions of patients, whether they'd be okay with getting a visit, some of these checkup visits from someone who's not their primary care provider. They might want the doctor. There's a certain, sort of prestige and or level of comfort with their primary care provider, who's often a doctor. On the flip side, there's increasing numbers of Americans with no usual source of primary care. And there's likely a variety of factors related to that. And I think there's this sort of, when we think about these visits and the sort of the push and pull about whether you want these visits to occur with someone's physician or their other type of primary care provider, like a nurse practitioner, what's the trade-off? Are you when the patient meets with that provider with their sort of usual source of care, is it good? Are you relationship building by doing these checkups with them, or are you taking them away from other potentially more high value um, tasks that they could be doing and burning them out and just adding yet another thing to their never-ending list of items on their to-do list. So there's this sort of push and pull about these common visits, whether they can or should or need to be done with someone's usual provider. All right. So I want to open it up for discussion. My question to the group that I'm hoping we can take a few minutes to talk about now is, which primary care population or populations, given all of the slides I just went over there, which populations do you think primary care practices should target or prioritize to maximize the value of these checkup visits? And as part of that question, which type of providers do you think should be delivering these visits? And just going over some of the issues I raised. So when you think about these visits, what are potential benefits that you're after in designing one of these sort of programs for checkup visits? What are your goals? Is it solely to increase preventive services uptake amongst patients? You're also seeking to sort of foster or bolster relationships between patients and their primary care provider, their usual source of care, increasing continuity of care, a very well-known sort of beneficial aspect of primary care, core element of high-performing primary care systems. Are there other goals you have? What about the disparities? Should we be targeting particularly sort of underserved groups specifically and target and over other groups? And what about resource limitations? Obviously, we don't live in an environment where we can be devoting too many resources to outreach to patients, or maybe outreach to all patients, and we only want to be prioritizing sort of higher risk groups. So without necessarily being experts on all of the information I presented on the prior slides, again, let me pose the question to the group. Which population or populations do you think practices can or should sort of target or prioritize for these types of visits?
Do you want people to go into the chat, Dave, or what's your
I
preference?
just I can't see the chat as
Okay.
far as I know on my
So you want
screen.
people
So
to
people,
unmute and give
yeah. So for if people just want to, if it's on the chat, someone can read it out. But I would go ahead and chime in. Sort of unmute yourself if you want, and just sort of let me know thoughts you might have.
anybody have quick thoughts to weigh in?
Hi, this is Michelle Dawson in General Internal Medicine.
Hi, Michelle.
Very, very good questions that you have here. I guess I would say that sort of a two-tiered approach could be, where you could do something that is very simple and low effort to message everybody, and then use resources like calling, having medical assistants call or whatever, for higher risk populations. I do want to comment, though, on one other thing that you said just a few minutes ago about not wanting to burn out physicians.
Mm-hmm. Are you a physician?
I am.
Please. And
Um, I work in the area of physician wellness, and I have heard from my primary care colleagues that one of the causes of getting burned out is that they're seeing, with the addition of advanced practice providers into the clinics, they're seeing fewer acute stuff that can be dealt with very quickly, and more chronic disease management, multiple chronic disease management, where there's not enough time and they can't catch up.
okay.
And so I think, these annual wellness visits could actually be a very welcome source for many primary care physicians, because it's more straightforward, perhaps a little less cognitive effort, And it helps reinforce that relationship, which I think is so important and why many people go into primary care in the first place.
Yeah. And maybe a little bit taking the focus onto their, their broader panel rather than more of the sort of multi-morbid patients potentially as well.
Yeah.
Okay. That it's always good to hear about, these thoughts of hearing from clinicians because yeah, you all are facing the pressures, right, to be um, completing these visits. And there's a lot of documentation, I think, especially with the Medicare wellness visits, but maybe I think I like the thought of potentially maybe it's some way to reduce the sort of intensity or cognitive load of their all of their sort of visits back to back there.
And that's not to say that physicians have to do all of these. Having nurse practitioners or others help out or offering patients the option and letting patients choose. Some patients
Hmm.
love their primary care doctors. Some patients would rather not go see their primary care doctor unless they had to. So given the option to do an annual wellness visit with another clinician might actually bring them in.
Interesting.
Anybody else have any? I had one comment, but I want to pause and see if there's any other feedback for Dave. The comment that I was going to make, Dave, at our event that you mentioned, the summit, the Rev PC summit that we had about, I don't know, 3 weeks ago now, one of the comments that came up was, is primary care having a visit with anybody on the team, or is it truly having a visit with your own primary care physician? And what does continuity mean? And so I think that's embedded sort of in what you're asking here. And I think
A
it
little
also,
bit, yeah.
yeah. And what we felt like is sometimes from the administrative standpoint, we're counting it as visits in the same team or in the same clinic, but we've sort of maybe lost the thread of continuity with a single provider a little bit in the last, I don't know, decade or so of primary care. So just curious if you have thoughts on that and how that fits in, because I think that actually does fit in to what you're asking about, and it fits into the equity piece of what you're talking about here.
Yeah. Continuity is something I started learning about from my dissertation chair, a guy named Rob Reed, who Courtney knew. He published a review on continuity, I think like early 2000s, and helped enlighten me that what are the three dimensions of continuity? It's information, it's management, and there's a third dimension of continuity. But if you think about just information and management for a second, right? If you are having one of these visits with another member of the team, and or someone else at the practice who knows your primary care provider, maybe bumps into them, maybe is really good at documenting things in ways that your PCP can pick up on, then I think maybe there's the issue of information. There is the continuity of information is being achieved. That said, I don't know about the management, right? If you're screening and you're talking to patients, a lot of these visits, maybe you're screening for depression, maybe you're screening for a variety of other things. And that management, certainly, I think it's taken away. Also, for some of the administrative measures of continuity I've looked at, there's like this Bice-Boxerman metric, if anyone's ever heard of that. It's a pretty simple sort of utilization-based measure. That would typically, in the typical sort of way that metric is used, a visit that's with someone else in the practice is a visit with someone else, and therefore it's reducing your continuity. And for all of these sort of core elements of primary care that are out there, care coordination, things like that, continuity is the one that really I find most consistently actually is associated with the most benefits, whether it's reductions in hospitalizations or potentially preventable ED utilization, reduced mortality, et cetera. So in a perfect world, without doctors who had other people on their schedule or clinicians who had other people on their schedule, I would want to see that same person over time as much as possible. What's reasonable there is a question, right? For the patient who is up to date on all of their preventive services, who is well connected to care in general, who maybe doesn't isn't from doesn't check box for certain high risk subgroups or other kind of social or other economic high risk groups. Do these visits have to happen every year, right? Maybe they can be every couple of years. But I think the issue of continuity is one that I continue to be a firm believer in. So that's a bit of a long and a winding response to your question there, Courtney. Maybe you set me up for that one. I don't know. Um, but yeah, the visits with someone else, I'm not. I I can't say that I see the potential benefits there. Certainly, if it's with someone who's on the team and maybe has more availability on their schedule, but then there's just that much less face time you're getting with your PCP, and the that can be challenging, particularly for patients who aren't well connected, have other risk factors as well. Anyone have other thoughts on what kind of checkups they would want to see for themselves or in a in their practice population or populations where they are working? All right. Well, I'll just some conclusions I've drawn. And I'll start with we've done this work, as I think you saw, in Medicare annual wellness visits. I think the over age 65 group is due to the potential mortality benefit, one that's good, that's somewhat easy to prioritize. And again, as I sort of alluded to within that group, we're trying to increase uptake in some of the non-white racial and ethnic groups there. But I think overall, patients who are age 65 and up seem like a reasonable population to target. I also think these days, age 45 and up, just the sheer number of recommended preventive services, or at least age 45 and up with overdue preventive services. By the time you're age 45, you got colorectal cancer screening, you got breast cancer, you got mammography for females. I think pneumococcal vaccination is now age 50 and up for everyone, flu, COVID vaccines, et cetera. Just the sheer number of preventive services, as well as, potential sort of onset of chronic illness in that sort of middle age, starting at, 40s or 45 maybe, is I think for population-based screening or population-based sort of outreach and encouragement of these visits, certainly every other year, maybe every year. So just some other things that I continue to wrestle with. I helped sort of with these choosing wisely recommendations or updated the recommendations a couple of years ago. And we said, don't perform routine annual checkups unless patients are likely to benefit, which is a little bit vague, but the frequency of checkups should be based on individual risk factors and preferences. And then that review I mentioned a few slides ago, we said primary care teams may reasonably offer general health checks or checkups, especially for groups at high risk of overdue preventive services, uncontrolled risk factors, low self-rated health, or poor connection or inadequate access to primary care. So that's somewhat broad, but I think in some ways, I think overlapping with what we heard from Michelle, I think there are certainly some groups where sort of population-based sort of encouragement of these visits makes sense. And then there can otherwise be sort of subgroups or subpopulations that we think might differentially benefit. Seems like a good place to start. Other thoughts before we move on to our topic number 2 of 2 here? Okay, let's talk social needs screening. Okay. I use this term social needs screening as a sort of proxy of health-related social needs. Some people say SDOH, but I think I use the term social needs screening for more immediate screening amongst more immediate identification of more immediate and maybe even addressing more immediate needs of patients. I'm about to cite some people who are in your neck of the woods here. So just a little bit of background. I think certainly amongst this audience, I would assume, and I think really broadly, these days, the importance of social drivers of health, SDOH, is pretty well known, pretty well accepted. And on that front, I think screening for patients' social needs has become increasingly common. There's these tools that are out there like Prepare, which can be long, but they're sort of well known and validated. This type of screening has been shown to be acceptable, if not necessarily to all patients, certainly to many patients, as well as many members of care teams if they're receiving the sort of the proper training and support. And as many of you may know, CMS actually for hospital inpatients is now requiring screening, social needs screening for patients in the hospital. Now that's, I'm talking about screening within primary care, but again, just for the background of how common this sort of has become and how it's embedded really in sort of some of the work that health systems are now required to be doing. Here is a little diagram we created for a publication I worked on. Sorry about the small text and all of the arrows, but this is a little bit of outline of the workflows that were done at least a couple of years ago. It's evolved a little bit since. At an FQHC I work with, it's called Erie Family Health Centers. Really great organization and collaborator in around Chicago. They launched screening, social needs screening at the very beginning of the pandemic, and were building the plane as it was sort of in the air. And we, as you can see up top, we call this sort of phase two. They had a phase one where they had patients had all these needs. They were trying to call patients. They had a huge backlog. They weren't getting through their list of calling patients, and they refined their workflows in a way that, at the least in the sort of roughly the second year of the pandemic, made things work a little bit more smoothly for them. And what they asked patients who came into clinic uh, uh, between 1 and 2 pre-screening questions, as we call them. So first, at the top, they asked if people were actually interested in being connected to community resources before they even screened them. Amongst those who said yes, they then asked patients, how would you like to be connected to resources? Would you like support from someone over the phone where they can get called by like a navigator who's employed by the FQHC? Or would you just like some information we can give you? We can send you a link via text and email. It was like a little, almost a search engine embedded with one of these tools. It was called NowPow at the time. It's now, I forget what it's called. It's called Unite Us. They merged with or got acquired by Unite Us. So it was a somewhat elegant way where they were only talking to patients who were interested in resources, and they limited the number of phone calls they had to make for their sort of overworked screeners and navigators. The problem being beyond the fact that it was challenging to navigate for people who ultimately screened positive and got received navigation over the phone. For the roughly half, you see this 43% here on the left who got essentially got sent a link via text and email. They were sent a link, and so everyone was given access to at least a tool they could consult, but all this effort goes into the screening program, and we didn't know whether these patients actually obtained services at these partners. All we knew was that patients were given the link. You could potentially do a check as to whether they sort of clicked the link or opened the link, but in terms of going beyond there, we don't know. We didn't know what was happening to patients. So there was all this work going in to sort of, potentially identify their needs or help them with needs they might have, but we didn't know what where they were going or what kind of services they were obtaining. On a related note that was sort of embedded in that first pre-screening question, so as many of you, I would assume, are familiar with Siren and their work, this is their great sort of 2022 review of the state of the science of screening. And this issue is one that always I come back to. It's the fact that social screening versus interest in assistance, and it was alluded to on the prior slide, but not all patients who screen positive for social needs are actually interested in receiving assistance or services. And it gets to the fact that we're screening people who, yes, maybe we can identify their needs that might give us or their care team a better sort of picture of these patients' overall sort of risk factors, and improve their provider's ability to provide patient-centered care. But if you're screening patients and you're taking the time and the patient's time and the staff time to screen them, and then they say, I'm not interested in any help, are you really using that time wisely? And it also gets to the fact, just again the resources required to be implementing these programs. And then here, pardon the small numbers here, but just another study by DeMarchis, I believe it's Amelia DeMarchis, that they had done prior to this review. And they looked at percent of patients who screened positive who actually were interested in assistance. If you take an average of patients in that right column there, it's roughly like about 50%. I think it's 52% if you just sort of take the mean of all that. So all this work is done to identify the subset of patients who have these needs, and then only half of them actually want any help or assistance. So it's a conundrum at the very least, and it's a challenge in terms of sort of resource allocation and efficient sort of delivery and offering of these programs. I working with some colleagues here thinking about a program we were trying to get up off the ground. We came to some assumptions based on the, what we thought were reasonable assumptions based on the literature. So if you're doing a program where you actually want to refer patients to external partner organizations, community-based, some sort of community-based organizations for needs like food insecurity, housing needs, domestic violence, you name it. We assumed that about 80% of patients would actually complete the screener because 20% would decline. They would just say, no, thank you, I'm not interested, or I think it's inappropriate. Of those who you screen, about 40% of those who screened would be positive for one or more need or risk factor. Again, this was based on data we had at this one FQHC we were working with in Chicago. Of that, based on that prior slide, only 52% of patients would actually say, yes, I'm interested in receiving services. Amongst those who screen positive for any needs, only 52% would say, yeah, I'd actually like you to refer me elsewhere to get help from a local partner. And then of those who actually are referred, only about half would successfully access resources. So you're talking about an FQHC. Again, we were using both the evidence base and some of the FQHC's data, and we would only about 8% of patients who were targeted, most of whom were actually screened, would actually make it to the bottom of this funnel, as we call it, right? That they actually would receive services from a community-based organization. Now, it's not zero, but again, you think about what's the goal of your screening program. If you want to be referring them to external organizations, if only 8% are ever actually going to be sort of utilizing those resources, that's not a super high number. So bringing me to my next sort of and last question to the group here. What do you think are some potentially and we can do many sort of, the sky's the limit, or feel free to think about a variety of examples here. What are some potentially sustainable, high-value models of social needs screening in primary care? And again, this doesn't have to be in FQHCs, okay? But it could be thinking about things like, what's the goal? Do you just want to identify patients with needs, so you know about their lives and their sort of social risks? Do you actually want some sort of service provision by like a community health worker in the clinic, whether it's signing them up for some sort of public benefits or otherwise? Do you actually want to navigate them to services at an external partner organization? Where are you doing what population are you conducting this in? Is it an FQHC, a very low income potentially population with a high burden of need? Is it in an academic medical system that's largely a lot of private insurance with a lower underlying sort of need burden? What's the dose or intensity of your screening? How often are you screening patients? Is it once a year? Is it more often? Are you proactively screening everyone in the panel in the clinic population, or just those who come in for screening, who might be a potentially lower risk subgroup of your entire clinic population? What about data sharing and referrals to community partners? How are you going to do that? Who's going to pay for it? Once the patient gets referred, who quote unquote owns the patient after they've been referred? Who's in charge of the patient once they've been referred to a partner organization? And again, obviously within the larger umbrella of course, there's we operate in sort of resource limitations and constraints. How do we do all this in a way that actually sort of is again potentially sustainable and high value? So thoughts, examples, pitfalls. Let me open to the group here.
Patrick, I see your hand raised. Can you unmute?
Yes, and I apologize if there's some background noise. So unfortunately, I hate to admit this, but our team does work maintaining, testing, and validating quality measures for CMS. And one of the measures that we have input now is the MIPS measure of addressing social needs. And so everything that you say resonates with me completely. I'm a primary care physician by background and lead a team that includes a variety of disciplines, together with Beth Magnan, who's in our family medicine faculty. So I just wanted to give you some numbers just to put a sense on,
Okay.
the magnitude of this problem. So in the testing for this measure, they tested about 1.5 million patients, 1.5 million patients for, in 6,800 cases, 0.4%, the patient explicitly declined social need screening. Okay, so much less than what you report and much less than we know in practice. Again, 1.5 million. In 60,000 patients, roughly, they went through the screening and no need was identified. For 6,700 patients, a need was identified, but no intervention was documented. And for 10 patients out of 1.5 million, the disparity, the need was identified, and the intervention was documented. So this
And out of
is
1.5 million?
Out of 1.5 million. So this is the demonstration of your funnel. It's even worse because this is dependent on structured fields in the electronic health record. Some of this information may be conveyed in free text and not captured, but still the funnel goes, in this case, this is food insecurity, which is the most favorable case. The funnel goes from 1.5 million down to about 60,000, down to 10.
Wow.
And that's in the public domain. That's the Yale group that actually developed the measure, testing it in their own testing environment.
Are these just inpatients, or it's primary care, or all the above?
Outpatient, ambulatory care.
Okay. I'm sure there's some lapses in data collection along that sort of path there, but it gets at this issue, right? In terms of, why are we screening, or what are we doing with these data after we screen? And how are we serving patients potentially, perhaps most importantly, after we screen?
Hi, Dr. Liss.
Hi.
My point is that
This is-
it's a bit of gospel, that everybody thinks that this must be the right thing to do.
Yeah, it's intuitive, but as your data
Intuitive.
shows, right?
But I'm waiting for the evidence, and I'm hoping that you can help generate that evidence.
Yeah.
Sorry.
Well, if I can get my grant funded by ARC, hopefully I can. Thank you. It was Patrick. And then it sounds like we had someone else there. Sorry if I interrupted you.
Sorry, yes, this is Gloria. I hadn't raised my hand and I just threw it up there. But
Hi, Gloria.
what I would be interested in understanding would be of the people who are not making it to the funnel, down to the bottom of the funnel. It would be interesting to have a follow-up with them to understand why did they stop at, let's say, the referral point. And from personal experience, I'm thinking part of it has to do with not being communicated to as a patient. What is the level of burden that's going to be put on me to go through this referral process, to find someone to meet with, how often I'm going to have to meet with them, to find time to be able to leave work, and in my case, it's work and school, to accommodate these services. When you start thinking about all those unknowns and maybe not receiving that information is why you fall out from going to the bottom of that tunnel. So maybe incorporating part of that in the screening process as like having a rubric already set up depending on the services that this individual is going to receive, giving them or educating them on that level of on what the whole process is going to look like and a time frame, and then what's the added benefit to them. I think we miss some of that, and I could be naive in that assumption.
I don't
And
think
that
you
could
are.
be a reason. why we are only getting 8% out from the initial screening.
Yeah, thanks, Gloria. The successful referrals to community partners is really hard. Beyond all the issues you mentioned, which are valid, and I think have been documented in the literature. I mean, there's questions about these organizations. Are they accepting new clients, right? The FQHC I was talking about of some of my first slides, it was during COVID. There was this explosion of need. All of a sudden, there were these organizations that might have had fewer hours and larger numbers of clients than they've ever had. So there was tons of challenges just with that, even if the patient could sort of get to or call the number for that external partner organization. So, and then the issues about are those is there reimbursement needs for some of those partners, or are they being reimbursed in different, the funding sources that they have, if they're often coming from different funding sources than the health clinic or the primary care practice is getting. So there's a question of what's needed there versus what's appropriate there. That's something that's being worked out. Certainly these referrals to any sort of external organization is actually getting the patient in. There are a million different sort of failure points along that path.
And Rich, go for it.
Yeah, hi, Rich Kravitz. I'm a general internist. It's in addition to just recognizing the limitations of the healthcare system as the cure-all for all of society's problems, a lot of these social needs really should be addressed at the neighborhood level and should be a matter of public interest, not necessarily relegated to the health system. But aside from that, I guess it seems one thing that we as health services researchers haven't really taken on is trying to prioritize, for all the work that's been done in cost effectiveness, but trying to prioritize services in terms of the benefit that they deliver to patients. So for example, missing a case of ongoing moderate hypertension has a number needed to treat of somewhere between 10 and 100, whereas missing a mammogram, screening interval has a number needed to treat of about 1 in 1,000. It's one invasive breast cancer death for 1,000 screenings, and you could go through this whole same thing. By the way, you did a great job of helping us with the taxonomy of checkup visits and whatever, and the services that are part of that. But there's counseling, there's immunizations, and there's screening. Maybe after yesterday with RFK in office, there won't be any immunizations anymore.
Yeah.
Think about that. But these services have different potential benefits. There's a limited number of hours of the day. You're familiar with the data that show that for a primary care doctor to do all of the recommended preventive services would take something like 26 hours.
Yeah, those are the best. The people who wrote those papers, I mean, the
So I
number of
guess I've made
citations
my
they have
point.
is incredible.
We need to prioritize, and we need to think more about
Mm-hmm.
highest value services.
Yeah.
And I'd like your reaction.
And I think I'd sort of tend to agree with you there, in terms of thinking about the highest value services and the needs. And given the challenges of these, getting through this funnel, as I call it, right? It doesn't need to be all 17 questions from the prepare screener that a practice is using, right? Are there particular needs that are common in your clinic or your local population, for that can feasibly be addressed either internally at the practice or with providers or with partners of the practice that are established partners or partners that you can establish some sort of collaboration with, right? I think starting in those things is going to be the best recipe for success, because screening for a bunch of needs, some of which you don't have the ability to address or the resources to address, that's a good way to waste everyone's time and make a variety of the stakeholders frustrated along the way. So are there things that can be done internally? Are there Medicaid applications or SNAP applications that a community health worker could help someone fill out, in the practice or over the phone? It could be over a session or two. Are there food boxes or other programs that either patients could be enrolled in by staff at the practice, again, like a community health worker or something like that? For connecting to external partner organizations, can you very clearly set some rules of the road whereby that practice that partner to a reasonable extent will not be overburdened by the amount of referrals and patients that are sent to it by the primary care practice? Is there going to be a reasonable amount of agreement and ownership or understanding of who quote unquote owns the patient, after a referral, whether there's data sharing or not? Whether there's electronic data sharing or some other mechanism, phone call or otherwise, what kind of tracking can and should be done in a reasonable, pragmatic way to be addressing these needs? Because as you sort of alluded to, there was a rich the health system as the cure-all for all of society's ills. They're showing up at those. I think some of those issues are certainly, there, you see the symptoms of those issues at the practice, but being overly ambitious for some of these types of really complicated interventions to identify and address social needs, I think smaller steps are certainly early on more warranted than attempts at huge leaps.
And I know we're getting close to the hour, but I'm going to do this academic thing that I hate, that I'm going to do it anyway. I have a comment and a question.
Fire away.
My comment is, I think a lot about the digital screening questions. So as one of the social needs about whether or not people own devices or have internet at home and things like that as a social determinant of health. And when I think about that as the need in which it is directly relevant for whether or not they're receiving care from the healthcare system, like whether or not they can schedule an appointment or refill their medicine or see their doctor. And yet we don't actually even do that well. So even a social needs priority in which it directly affects their ability to receive services and the way in which we want them to receive services, I see that as we don't have time to do that, right? To screen for that in order to help people navigate our own systems, let alone refer them to food and other things that they need in their daily life. So that's one comment I wanted to make. And then the second is, I think the overarching thing in our last minute, I would love you to reflect on, these are difficult questions to build a research career on. They're very intersectional. They have a patient preference component, a clinician practice component, and a system level in terms of the tension between access and, be able to deliver high quality care. Can you give us any advice or leave us with any words about how you think about that from your academic career, how to tackle such thorny questions, and any advice?
Well, I wish I had an easy answer for you, and I could tell you that I was swimming in successful grants for some of these things. I think, and thanks, Courtney, for the comment and the question. I think what I have been finding for some of these questions is, in terms of the academic issues, is I think they're publishable. I think they're interesting to a lot of partners, so it's a fun sandbox to play in. As tough as the funding has been to get in some instances, I've been at least encouraged by the what's the word? Sort of the flexibility. I don't think that's the right word, but the portability of some of these issues, where we can slice off some of these things that might be relevant. I talked about the Medicare annual wellness visits. That's a grant that's funded by the National Institute on Aging that I was able to get. A smaller one though it was, but hopefully that'll lead to bigger things, right? The social needs screening, it's a grant that just didn't get funded by AHRQ. That was a second generation idea of something that didn't get funded by Robert Wood Johnson Foundation. So there's disappointments baked in here, But as I try to keep my batting average at a sustainable level for some of these things, I think that these ideas are at least portable enough where, if we wanted to make it disease specific, I haven't gone down that road yet. But in a large practice, there's potential to be doing that. I mean, as some of you probably know, there's someone who I certainly can't compete with. It's Seth, what's his name at UNC, does a lot of the food insecurity
Berkowitz.
stuff. Seth Berkowitz for patients with diabetes. And that's really, I think, really interesting, super, Seth has sort of lapped the field in a lot of this stuff. But my hunch is that it's probably a lot of NIDDK funding he's gotten for some of that work as well. And I'm still trying to get better at that, but I haven't, I when I've been sort of, swinging and missing, I haven't fully struck out yet, shall we say, to use the baseball analogy for some of these things. So I think there's legs, there's detours, there's things I can slice off that even if it's just focused on a certain age group, it's still relevant, I think, to these questions overall, and can fit within these academic silos that we sometimes need to sort of navigate between.
I think that's a perfect way to end because it offers some hope, but also primary care research is kind of hidden. It was another thing we talked about, and how to make it its own area and to think about methodologically rigorous questions that are across the levels, and is something I think we can all push for as well. It's really going to take that in order to change our lives, to change how we access care and all that. So I think, thank you for committing your career to this, Dave. It's really amazing. Really appreciate your wisdom, and I think people can contact you if they have follow-up questions.
They can contact me, and I sent my slides to Bill, the PDF, if people want those. I can send them to you, but Bill has them if you just want the PDF of the slides. That's certainly fine as well. But thanks for having me.
We're so lucky to have you for an hour. Thank you again, and thank you everyone for coming, and have hopefully a great rest of your day. Thanks, everyone.
Thanks all.